200. If you're following in your notes, we're on page 5. Hip flexion. What are my landmarks going to be?
KSI.
Hip flexion, what are my landmarks going to be?
Greater trochanter.
Good. Greater trochanter is my fulcrum.
Yes.
Lateral epicondyle of the femur is my moving arm.
Lateral midline of the pelvis.
Good. Lateral midline of the pelvis or trunk is my third. Couple of things to consider. Number one, why do I not want to test her hip joint this way?
That's the insufficiency.
Number one, it's too distal. I'm crossing the knee. Number two, passive insufficiency of what?
Hamstring.
Very good. So what do I need to do? Good. I'm going to measure it by bending the knee. Remember to palpate the greater trochanter. In patients, especially heavier patients, you might need to rotate a little bit. It might not protrude as much. Do orient your patient to that structure. You might need to ask him or her to put a finger on it at times as you apply your goniometer. So let them know where it is. Something else to consider. If I have Nicole bend this leg, and then I bend this knee, and then I flex her hip, what might be happening to her pelvis?
Tilting.
Good. So am I any longer measuring hip flexion?
No.
Okay, so have to avoid any posterior pelvic rotation. We're going to keep the contralateral leg straight on the table, and it's going to help maintain that neutral pelvis. Also, make sure you maintain pure sagittal plane motion and not get into the habit of allowing that leg to slightly externally rotate because you will increase your number. So we're sagittal plane, contralateral leg is straight, and we're making sure the pelvis is remaining in a neutral position. If you need additional stabilization, you can stabilize on the ASIS to do that. So far, are you with me? Take the leg through the passive range of motion. Any symptoms with that? We're going to get our end feel. We have a firm end feel here at the end of range, estimating probably 130 degrees or more of flexion. Take our patient out of it. Reset your goniometer to 130. One more time, my landmarks are? Good. Greater trochanter is the fulcrum, lateral epicondyle of the femur, and then midline of the trunk. Point to your greater trochanter for me. Good. And would you keep one finger on this greater trochanter? Thank you. At this point, can you guys see better if I do the other side?
Can't find it. Okay, I found it. Oh, I can't find it like that.
Just when you get over here. Sorry, Alan. Okay, so I'm going to take her through her full range of motion.
Did you say to move?
You can move if you like. I just want you to be able to see. Once she's there, there we go. Thank you. Once she's there, you can move your finger. I get my range of motion.
Can I ask you a question?
Yes, ma'am.
You said her infield was hard and our expected infield is soft.
I said firm.
Firm. Okay.
Soft or firm. You would expect more soft tissue approximation. It felt like there was no soft tissue there blocking it. It was just the hip capsule limiting it.
Okay.
Soft would be closer to this where it was much spongier or springier.
Okay.
Questions about flexion? All right, extension, if you'd please lay prone. We're going to use the same landmarks for extension. Tell me why I don't want to do this.
She'll be
That's the
already
insufficiency.
lifting up her
The
back.
quad.
It's her quads extended over two joints.
Okay, so add what you guys said together.
Passive insufficiency of quads.
Good. Passive insufficiency of the rectus femoris if I flex the knee and then concurrently try to extend the hip. So provided your patient does not have knee pain, please do this with the knee extended. If your patient does have knee problems, you can gently flex the knee without causing any problems just by getting your wrist around it like that. but it's ideal to keep the knee extended. Do you have any knee problems?
No.
Okay. Now, I'm going to place a hand underneath her ASIS in order to feel for when the pelvis starts to anteriorly rotate. When the pelvis starts to anteriorly rotate, or the lumbar spine starts to hyperextend, I've reached the end range of the hip extension and the test is over. So can I also lift up your shirt?
Sure.
I'm going to keep my eyes on her lumbar spine. I'm looking for any extension of the lumbar spine or feeling for any anterior pelvic rotation at the ASIS.
It would lift off the table at that point.
No, I would feel the ASIS pressing down into my finger. So right here, her hip stops moving, and I see additional motion is recruited out of the lumbar region. It's a firm end feel. So you guys can see, I'm going to do it again over here. I have one hand placed underneath the ASIS. I have my eyes on the lumbar spine. This is the point where the hip stops moving and the lumbar spine starts to hyperextend. It's probably about 30 degrees. Right there, position, and measure. So when it comes to the hip especially, thanks Nicole, when you've maxed out the range of motion of any hip motion, if you continue to apply a force to your patient, motion is going to come from somewhere else. So when the hip is no longer available to move, range of motion is going to be solicited at the adjacent joints, which is the pelvis and the lumbar spine. If you see motion occurring at either one of those locations, that's your end range, right there. Flexion and extension. Go ahead.